Good evening, everyone. Thank you for joining us this evening and welcome to our today's webinar. My name is Dr. Mahadar Garrett. I am a Doctor of Dental Medicine graduate from Addis Ababa University, and I will be moderating this session today. Our speaker this evening is Dr. Manish Kumar Khazane, all the way from India, a leading endodontist with extensive experience in root canal treatment, retreatment, digital smile design, and veneers, who will be discussing with us about crucial aspects of restoring teeth after endodontic treatment, various techniques and materials used in post-endodontic restoration to ensure long-term success and optimal patient outcome. So we have happy patients, happy dentists, am I right? So before we begin, a little bit about our guest today, Dr. Manish Kumar Khazane. He's a leading endodontist with a Bachelor of Dental Science from NTR and a Master of Dental Surgery from SRM University. He runs a microscopic enhanced dental clinic focused on retreatment, endodontic, and biomimetic dentistry. He is a recipient of the Jean-Marie Larouche's research granted by IFEA and is an award-winning researcher. Dr. Khazane also serves as an editorial board of several global journals. He is the co-founder of Dentinova and MSAI, working to improve oral health access and education, and as the founder of the Microendodontic Training Center, Hyderabad. He trains clinicians through advanced online and enhanced hands-on courses. So quite an impressive experience. Very honored to have you, Dr. Khazane. Welcome on the behalf of EDPA and the attendees as well. So before we begin, I would like to inform you that this session is being recorded, and I encourage you to use the Q&A functions throughout the presentation so that you can submit any questions you may have. And Dr. Khazane will be addressing as many possible during the Q&A session at the last 30 minutes of the webinar, and hopefully we will wrap up around 7 p.m. So without further ado, I'd like to welcome our guest, Dr. Khazane. The floor is all yours.
Right. Good evening, everybody. This is Dr. Manish Khazane from India. Thank you, Dr. Garrett. Thank you, everybody, for the lovely introduction and for your time today. As we have assembled here to learn a bit about post-endodontic restorations and their importance in our day-to-day dentistry. So, yeah, without further ado, let me start off with the overall contents that we'll be covering today on this lovely topic. That we'll be doing a bit about introduction, right? The history from the wooden post to the advanced mechanisms which we use today, the biomechanical concentrations of the dentin substrate, and how is it important in our day-to-day dentistry, factors and the challenges in restoration of these endodontically treated teeth, risk factors as well, which might lead to fractures, and preoperative evaluations, post-endodontic materials which we use, and obviously the newer advances which have come into the market to help fellow dentists. So let's get started with this. The post-endodontic restoration topic, right? So the primary function of the human dentition is obviously to chew food, allow us, to bite properly, to chew properly. And this process is a transfer of masticatory forces, which are being mediated by our very well-known teeth. So the overall synergism of the enamel, the dentin, that is the coronal, and the root dentin creates an integrated organ that is capable of supporting such high masticatory stresses and also allow us to have all the wonderful food which we eat. So what happens when these teeth are endodontically treated? So the root dentin is more important structure that is integrated with the muscle bone support, right? So the human root dentin has higher fractional strength and more significant, inelastic deformation than the coronal dentin. That means it's much more stiffer. And when this overall tooth crown is compromised by caries, defective restorations, fractures, and so on and so forth, the root canal treatment is indicated, right? So the endodontic treatment is mainly purposed to remove the infected tissues, clean the root canal space, and to control any kind of periapical inflammatory responses and infections. And all of this, when achieved, will give us a successful foundation to restore the overall tooth, function. So, however, it was reported that some of the failure cases of endodontically treated teeth are resulted from non-microbial factors as well as biological factors as well. We need to understand here when we talk about post-endodontic restorations and how these are important to make our teeth strong and for them to defend or to sustain all those high masticatory forces. We will dive into a little bit deep into the overall structural configuration of our tooth. So the dental collagen makes a considerable contribution to the mechanical properties of the dentin, right? Changes in these collagen fibril crosslinks, right, may contribute to the brittleness of the endodontic treated teeth. And while this root canal process goes on, loss of the pulp vitality during the endodontic treatment, or due to infection, or due to structural loss, or due to fracture, there could be a number of factors that are leading to the endodontic treatment, right? But all of them are also one of the contributory factors, right? So the performance of this ETT, that is endodontically treated teeth, is strongly related to the biomechanics and strongly related to the overall tooth structure. So we will get into this dentinal substructure or substrate, that is a complex mineralized tissue arranged in an elaborate 3D framework. And we all know that dentin is composed of intertubular dentin, peritubular dentin, right? And the dentinal tubules, which carry our odontoblastic cells. All of this contribute to the overall dentinal structure, right? And what makes it stiff, what makes it sustain so many forces, is the very much configuration of our collagen fibrils and the overall tubular structure of the dentin. This mechanism, as shown in this picture, shows you how the crosslinks are responsible for the stiffness of the dentin. And when we compare our dentin to the bone, obviously the bone does not, the dentin and the bone are two different parts of the body. And when you compare the enamel, the dentin is better, wherein you have these substructures, you have this collagen scaffold where you have an opportunity to develop and progress in terms of remineralization and regeneration, or in short, regrowth of the lost tissue. So it is a very good advantage which we have with our dentin. And this is the type 1 collagen, fibrillar forming collagen, that is the basic part of our dentinal structure. Further, going into a little more deeper into the how the morphology of those collagen fibrils are. So why are we talking about collagen right now? Is because that is very much responsible for the stiffness, mechanical and functional integrity of the dentin, right? So this is how the crosslinks are formed. These are the micro structural configuration of the dentin, which is overall responsible for our stiffness of the tooth as well, right? So our dentin collagen is extra special, yes, and it is the most cross-linked collagen in the body. And dentin collagen does not metabolically turn over, does not easily degrade, but once it is lost, it cannot be replaced. So again, the reason for stability, as I was telling you, was due to the cross links and also due to the hydrogen bonds which are present inside these crosslinks, inside these collagen fibrils, which bring the stiffness, right? So as we were saying, it does not turn over. The natural crosslinks accumulate over time and can influence the mechanical properties of the collagen fibrils. And these collagen crosslinks are responsible for the ability of the dentin collagen to be acid etched during bonding procedures without denaturing its collagen, right? Once it denatures, it is lost. Once it is lost, our overall structural configuration gets affected, and that's how your longevity or prognosis of your tooth gets disturbed. So that is the importance here, which we need to remember. Overall, other factors, again, as we have gone through the collagen altercation, just a summary of how what we were talking about right now, dentin structure, the collagen arrangement, and how an endodontic treatment affects these crosslinks, right? And how this overall impacts our tooth strength and what are the clinical implications which we must consider during restorative treatments, right? So the next part which affects or is responsible is the role of the moisture inside our dentin. So the moisture inside the dentin is also important, and this uh, moisture is due to the water present. There are two types of water present in the dentin: free water and the bound water. Free water moves the ions and can be removed at 100 to 110 degrees centigrade. This was reported in a study. And the bound water is attached to the hydroxyapatite crystals and is not lost until 600 degrees centigrade. And once the moisture is lost, it cannot be fully rehydrated, even in humid conditions, right? So once the collagen fibril network loses its moisture, gets degraded, denatured, it's very difficult to bring it back. So that is the overall importance. And the whole purpose of the slide was to say that pulpless teeth may be more brittle than a natural tooth. And the contributory factors here are all of this, right? And the architectural changes in the tooth. When we say architectural changes, we can say about, again, the contributory factors like the loss of tooth structure due to caries, loss of tooth structure due to fracture, right? And once the tooth structure of the is lost, then we obviously get into the endodontic treatment, and uh, the overall endodontic treatment. Again, we need to remember how we are doing the axis preparation, the conservative axis or the ninja axis. There are a lot of axis preparations. We always need to remember that what you can treat is only what you can see, right? So if all you need to do is keep in mind while doing an endodontic procedure that you need to be able to see your canals, you need to be able to clean without making a lot of stress on your files, be it hand files, rotary files, get a straight line access, right? For all of that, your access preparation should be adequate. A. B, at the same time, you cannot be irresponsible while doing the access preparation during an endodontic treatment and cut a lot of dentin. So we should keep in mind, practice, and try to perfect our access preparations to reduce this fracture risk as well. And obviously, while preparation of those canals, we all know about the smear layer formations, and all know about the EDTA, which is being used to remove the smear layer. Overuse of these agents can also weaken the tooth structure. And here, uh, when we say weaken the tooth structure, the EDTA has a direct effect on the dentin that contains the collagen fibrils, as we had discussed, and that reduces or degrades the collagen fibril crosslinks and thereby causing the loss of stiffness. So that's how all of this is a vicious cycle, and we need to keep in mind always to be very careful right from the start, so that you can have a fantastic result for your patient at the end. Right? So I was talking about how there are various types of conditions or situations which we see in our day-to-day practice. There could be an extensive loss of tooth. There could be, two canals, and there could be a certain way to produce, guide your axis, like for our upper anterior, maxillary anterior central teeth, right? Central incisors. And lower central incisors, lower lateral incisors have a different configuration. Sometimes they have two canals. So overall, they are, smaller in tooth structure also. So all of it actually depends right from the start. Even if we are planning for a post-endodontic restoration, you should also plan your endodontic process perfectly. Once you do that, your post-endodontic restoration will also land in a perfect way, providing the longevity which we all require, right? So next is the tooth and concerns, right? So as I was saying, importance of the root anatomy before placing the post. Not every endodontically treated teeth needs a post, right? The root anatomy must be carefully assessed uh, for for successful endodontic treatment, as well as placing your post or any other.
All right, I think Dr. Khazane is having a little bit of speaker issues. We're working on it. So far, just to revise what Dr. Khazane has been saying is the importance of collagens and dentinal structure, as well as perfecting our access preparation in order not to compromise the existing dentin. And also he has been discussing about the uses of EDTA and the overuse of EDTA, which in that circumstance might have a direct effect on the collagen fiber cross-link. And the second thing that Dr. Khazane has been discussing with us is also moisture loss, which cannot be replaced or rehydrated. So keep a note on that. And also, you guys, if you have any questions, you can forward it on the chat box, and I will be keeping up with your questions and forwarding it to Dr. Khazane at the end of the session. So yeah, definitely keep doing that.
Right. I just lost my connection. Am I audible?
Yes, Doc, you're audible. You can continue.
Right. Thank you. So sorry, guys. There was a power connection issue here. Anyway, so right, as I was talking about the anatomical considerations, you have to know the anatomy. You have to read your X-rays. You have to plan your treatment all along, right? So maxillary incisors, canines, these have enough root thickness for the post, and at the same time, you need to know the direction while doing your axis, the direction of your piezoreamers or your drills, GG drills. How are you trying to prepare this post space, right? So once you know the anatomy, once you know the pathway, then obviously you can do the endodontic treatment, you can do the post endodontic treatment, you can do anything perfectly, right? So we need to remember the anatomy always. And you need to know the angulations. You need to know which post which canal rather would be better for our post, right? So for the upper molars, we always say that palatal canals would be the best choice. And however, 85% of these roots curve, right? So if there is a root curvature, and if we are planning for a post, we need to understand the anatomy first. We need to read our X-rays. That's why our pre-op, post-op X-rays need to be our guiding friends here, right? Even for the mandibular teeth, as I was saying, the incisors have lesser or thinner roots, and they might have anatomical differentiations in terms of two canals, and there's an angulation issue in the lower premolars, right? So you need to realize how you're doing it. Guided approach is the best way to go. Always take help of your radiographs. Always take help of your knowledge. Learn about them, and misaligned drilling can cause perforations. That's just what written in the potential issues, right? So all of these curved rows, multiple canals, all of them can be read, and we can be prepared. So never treat what you can't see. You always need to understand what you're doing before proceeding forward. So obviously, to ensure a fluid tight seal of the root canal and appropriate restoration to prevent fracture, this is the aim, right? So for the endodontic treatment, and to restore that tooth form, function, aesthetics, right? And prevent any type of coronal micro leakage, reduce the wear and tear, and preserve the periodontal tissues. All of these are the objectives which we need to attain while doing this restoration. And the challenges, as we were discussing, was loss of physical properties and biomechanical challenges. All of them have to be kept in mind, right? And the sound structure preservation is the key to survival rate. So that's why I was telling while discussing with the access preparations slide, that if we can be able to manage that, have conservative access, I don't need anybody to, or at least per se personally, I don't think that we need to have that ultra ninja access, which we do under microscopes, which even I practice. But I always say, clean it properly, open it, do the access preparation as much as possible, which is required, right? So that you can have a straight line access to your canals and never stress your files. If that can be achieved, then the access is fine, right? So you need not do too much, you need not do too less, somewhere in between, right? So, and obviously, the tooth type and the position, the occlusal contacts, any kind of parafunctional habits, if your patient has, make a note of it, and plan your treatment for all the way along for the post-endodontic restoration accordingly, right? And coming to the history of all this post-endodontic restoration, it started in way back in 1728 to 1800s, and basically they were using pivot crowns, which were used made from wood earlier. The disadvantage there was the wood used to absorb the moisture, swell up, and thereafter cause fracture, right? So thereby, you know, being of no help here. So furthermore, we developed locks, lost wax casting procedure for custom cast post and core, right? Which we used metal, porcelain, resin composites thereafter. And right now, the best method which we use are rebond, right? And fiber reinforced composites and fiber post, which are being regularly used in the practices here, right? So this is a comparative image where you could see that wooden hickory posts which were used earlier to the present ones where we use biomimetic 3D rebond endodontic post-in-core material, where it gives a strong core so that you can go forward with your prosthetic uh, you know prosthetic tooth structure. So yeah, so factors and challenges in the restoration of endodontically treated teeth are: the teeth needs to be fracture resistant, remaining tooth structure should be there, it should not be in a patient should not have parafunctional habits which are going to damage all the work which we are doing in terms of post endodontic restoration. So that space needs to be checked. Ferrule effect is what we would be discussing. Biological width and any kind of secondary caries, all of this needs to be considered, and they affect our restoration, right? So we'll be discussing.
All right, I think we lost Dr. Khazane again. Just to recap everybody. So the main thing that he has focused on the last minutes is candidates of post placements, where we should note on anatomy of the root canals, where there is curvatures or all anatomical variations on the canals. And the key giveaway here is that we cannot treat what we cannot see, which means radiography is a must, and we should do an X-ray pre-op as well as post-op. Post-op. And the second thing that he mentioned is maxillary canines and incisors. Those are the main candidates for post placements, which is very, for obvious reasons, the anatomical structures here is very much direct, as well as a great root canal width. And also the third thing that we should be cautious of is the directions. Where are we placing these directions? So yeah, we should very much be aware of those so that we cannot make any perforations, as well as the last point mentioned was marginal till. So we have to make sure that moisture control is a must. So yeah, those were the key points. Again, I'd like to encourage you guys to raise any type of questions so that we can forward them to our guest in the last couple of minutes where we will be answering the questions. Yeah, so stay tuned for that, and you can write us, chat us, forward your questions or any ideas that you may have for us. Yeah.
Yes.
All right, Dr. Manish, we can hear you now. Are you available?
Yes. I'm really sorry. I seem to be some kind of issue here.
Uh,
So
Problem.
going forward, the remaining tooth structure, biological width, uh, and the ferrule effect, we'll be discussing both of them in the next few slides, and the impact of crown to root ratio as well, right? So uh, can is my screen visible?
No, doctor, your screen is not visible, but your audio is perfect.
Oh, I'm sorry. Let me
Okay,
just check.
just take your time and we can fix that. All right. All right, Dr. Kazim, now it's available for us.
Thank you.
Okay.
So, this is one of the wonderful images which we had received from a study, which shows you how caries affect your tooth structure, and the subsequent images are focusing on the amount of stress distribution that happens in such a tooth, and you can see how uh, the such stresses which are spread till the root of the tooth uh, can be responsible for a fracture and how this happens, right? So um, it's a wonderful image here, which we, helps us to imagine. And I always say, try to remember or keep in mind of such moments or such images of various topics, if it's not only about this particular topic, that you can correlate when you go back into the practice. And that will give you that, importance and the whole essence of being a responsible dentist and taking care that you don't over uh, you know remove or over prepare your tooth for a restoration, for an endodontic practice, for a tooth preparation, for anything per se. uh, Such images help us to correlate very well in clinical practice. So the next one is the occlusal forces. Bruxism, if the patient is suffering from any kind of bruxism, you need to make sure that your prosthetic part as well as your restoration should not be in a zone of direct impact, right? And it could differ for your anterior teeth, and it could be differ to your posterior teeth. There are a lot of forces, shear forces, which are acting in our oral cavity. So this is also one of the factors which need to be kept in mind for endodontic restorations. And the ferrule effect, I'll be discussing in detail in the further slides. Full cuspal coverage, partial cuspal coverage, endocrowns, these are the decisions to be taken. And it depends on the amount of extent of damage, right? And based on the extent of damage, you decide whether you want to give a full coverage or partial coverage in terms of inlay and onlay, right? So that is to be looked into. Any kind of coronal micro leakage should not be present, and secondary caries need to be dealt with. All of these factors should be done properly or should be addressed sufficiently well before we proceed to the post-endodontic restoration. The other risk factors include the chemical factors I was talking about earlier, where use of these irrigants, use of EDTA while cleaning and shaping can cause our tooth to degrade. So that doesn't mean that we do not use it, but that also means that we need to be uh, conscious about the protocols, how we are trying to use them, and also correlate with your present tooth structure condition. The microbial factors obviously can be dealt with if your endo is proper. So if there is untreated canals, if there are additional axillary canal structures inside which have not been cleaned properly, then that could also be one of the risk fractures, although not for the fracture part, but definitely for the microbial contamination and a position where we might need to reperform the endodontic procedure, right? And age factor, as we all know, the teeth naturally loses some of its resilience and strength. And in our older patients, the tooth might be more brittle and may have those tiny micro fractures when you see such patients. So you need to remember that preservation of the natural tooth structure is utmost important for such patients. And we need to be able to perform our uh, the post endodontic treatment, or as well as for the crowns, for whatever it might be, the structure needs to be very carefully dealt with. So what do you do before all of this story begins, right? You need to evaluate your teeth. You need to see Is there any swelling? You need to see if there are any extraoral, intraoral swellings or any kind of discolorations over your gums, right? You need to see your tooth position, right? And you need to see the aesthetic evaluations, right? So aesthetic evaluation means what? Amalgam restorations might be there in your patient, which is causing that staining over the gums, right? That could be also one of the factors. And in such patient, again, if you're trying to, you know, not deal with that and going forward, then obviously you will not get the desired result later. So you need to keep that in mind. Periodontal evaluation and obviously the biomechanical evaluation. So extensive loss of tooth structure, and we think everything can be saved. Then no, right? Shear forces will be in play. Coronal tooth structure is of utmost importance. Post is only to help you, only to make the teeth a little stiffer, but that doesn't mean if we have extensive loss of coronal tooth structure and we place a post and we think our, the life of the tooth is going to be not guarded, rather very good, then that is a false statement, right? So we need to remember all of that, evaluate all of this, and for a good result at the end. So therefore, it was important to understand all of that biomechanics to restore the tooth to bring the best result, right? So what is the material which is most appropriate, right? Is it a direct or an indirect restoration that would be better? Is it necessary to cover the cusp structure? All of these we need to be covering in the further slides, right? So all of this was done for what? For increasing the longevity of the endodontically treated tooth. And what other steps that have to be kept in mind or can be taken are all of this, right? So mechanical effect, performance of your endodontic files. Even before the performance of endodontic files, as I was talking, you need to remember how you're providing that glide path, how you're providing that perfect access as much as possible, keeping in mind that you're preserving the tooth structure, but at the same time, giving your files enough breathing air to, not be under stress and do their work, right? So then comes the restorative materials, and obviously the post selection design, the length, the diameter, and quality and quantity of the remnant coronal dentin structure, right? All of that has to be kept in mind further. So the impact of endodontic instruments on the root dentin integrity. Again, once the access has has been performed properly, I always say or believe that we need to be very clear about our pre-evaluation stage. Face the fact, share the same with your patient, let them know, and you also should know what you're going are dealing with and what would be the probable prognosis and what are the precautions as a clinician you should be taking here, right? In all of that scenario, our endodontic instrumentation cleaning is very much important, right? So you need to prepare your glide path properly, use the good technology. At least I would not say always to invest a lot, that again depends on our area to area, but you should be using good quality endodontic instruments, right? Prepare a glide path. The hand files are our heroes. Then comes the rotary files, right? Respect the curves of the tooth. This will also help us while we are placing the post or while we are planning any kind of post-endodontic restoration. So the root canal treatment, if done properly without aggressively, preparing our tooth, uh, will also be one of the advantages that we'll have, right? So in one of these studies, they have mentioned about the self-adjusting file, that is SAF system, and which is like a meshwork structure, right? That that rotary file, which is going to cause less stress and preserve more tooth integrity, right? That was reported by them. But you need to judge where, how you're going, what is your cleaning protocol, how much tooth structure are you removing, root structure are you preparing while this endodontic treatment is being done, right? So there's 4% files, 6% files. You need to know which one to use, because that story doesn't end there. The story continues when your treatment of endodontic treatment is successful, and then now we need to continue for our post-endodontic work also. So it's a continued story. So just always remember that. Then obviously we discuss about the custom cast post and the core. When the large portions of the clinical crown has been lost, it is often impossible to achieve sufficient anchorage for a crown. So that is where a root canal retained restoration is required, and it might require crown lengthening as well. It might require proper endodontic treatment as well, right? So all of those factors which we had discussed so far have to be applied in your clinical cases as well, right? So always remember that. So, and those posts could be prefabricated post or custom cast post, right? So that has to be decided. Cast post and core restorations have been educated for decades, and they have been a gold standard. There are various metals which are being used as cast post materials. There are also various types of those materials which are being used. So has it lost its relevance? No. It is only that now, with the higher technology or advanced studies and the knowledge and all of the research that we should acquire and keep in mind or keep us updated, that you have an option to decide where is it really required, and how, which type of it is really required, right? And whether it should not be a blind decision also. If you can always avoid the post, and if you can always avoid removing lot of tooth structure, so that you can directly proceed with the best prosthetic crown, right? So unless the coronal tooth structure is heavily damaged, that's where we require our post to take help from the root structure, right? So a post definitely is a dental restoration that is fitted into a prepared root canal of the tooth that has been endodontically treated to provide additional retention, right? And this is the coronal aspect. There's something called ferrule, which is a 360, encirclement of the metal band that goes around that tooth structure, and that gives additional, resistance uh, form, right? Ferrule effect is the actual bracing of the final crown over the remaining tooth structure that prevents fracture. So this is one of the most important parts that we should keep in mind, and it is always helpful. So what is the most difficult aspect of all of this? Now we know all of that story. We know, yeah, dentin, we know collagen, we know the tooth structure needs to be preserved, access preparation needs to be proper, our files need to be preserved, be the best, we need not over prepare. All of that story, all the factors, all the risk factors we know. What is the most difficult aspect now after we acquire all of this information is case selection. So you need to know where to apply all of this information, right? So you need to again judge where you can use this knowledge, where you can apply based on the clinical case which you have in hand. Always assess the amount of remaining tooth structure, the anatomical position of the tooth, the functional requirements of the tooth, right? Aesthetic requirements, most importantly, right? So to restore the function, right? So where can be used? Moderate to severe loss of the tooth structure, right? Best for single rooted teeth. If they are tapered canals, it's much easier. Best, these are the best indications which have been placed. And You can use multiple post and goes in the same arch if required, right? And smaller teeth like mandibular incisors, they say that it is indication, but I would say always be very, very careful when you're doing lower incisors. Even while preparing your root for an endodontic procedure, I would say the amount of coronal or the amount of dentinal structure around that root in a mandibular incisor is concised and it's not so big. So do not prepare your lower canals extensively. Always try to limit them, and so that you can preserve the tooth structure and have a good life for the patient in terms of that tooth, right? So there are prefabricated posts which can be used also if the sufficient tooth structure is present. And the advantages of all of this is the higher strength and minimal alteration of the root canal anatomy. It fits into the canal shape if it is customized, and good for oval canals. It is an integral part of the post, and you can even change the core angulation if possible, especially for the lower premolars, as we were talking. Sometimes, and the tooth anatomy changes, and according to that tooth anatomy, you need to put a post. So you cannot do a prefabricated post in such an angulated tooth, right? So you should be able to do a customized post, taking a wax and fabricating your customized post, thereby achieving the target. That is also one of the good advantages there. And obviously, the drawbacks is the rigidity of this cast post can also result to fracture, and it causes a wedging effect. So over preparation should be avoided, and it's an extensive procedure, delicate procedure, technique sensitive procedure rather. So you need to be uh, very conscious about your preparation while using your drills, right? There's no safety lock, there's no safety speed there. It's all on us to be clinically strong while doing this post-brace preparations. And obviously, it does take multiple visits, at least two, to complete your whole prosthetic part. So, patient should be educated about the cost as well. And the metal post per se has an aesthetic appearance. So, however, we have overcome that now with the advanced, uh, aesthetic, more aesthetic posts, right? So post length, diameter, design materials, all of these factors should be kept in mind as well, right? The post length is always equal to the crown length, or two-thirds of the root length. So these are the two important ones which we should keep in mind, ultimately not disturbing your apical seal. So apical seal GP should be there till at least 4 to 5 mm. That's good enough, and thereafter you can put your post. So always remember that uh, apical seal should be maintained, and thereafter your post should be placed. So for periodontically involved teeth, at least half of the length of the root, right? And more than 4 mm apical to the level of the crestal bone. So as I was saying, your apical GP is 4 to 5 mm. Best to retain that 4 to 5 mm. Why? Why to retain that 4 to 5 mm? Why to retain is because a lot of axillary canals are there at that apical end of the tooth. Lot of apical lateral accessory canals rather, right? And care should be taken that we do not expose them. Uh, so even after cleaning, shaping properly, scouting these axillary canals is a skill. And it's not necessary that we can, acquire that passage every day. So it only makes sense that you clean shave properly, do your endo, and while post preparation, maintain that last 5 mm. Do not disturb it, and then do your post paste preparation. That way, your endodontic procedure will always be safe. Thereafter, your problem is your post endodontic space and how you're going to restore the tooth, right? So that is one of the most important parts there in terms of post length. And diameter, obviously, preserve the tooth structure. Again, avoid perforation. You need to know the anatomy. You need to study the pre-op X-ray, uh, so that you can minimize any kind of perforation as well as the root fracture in the future. So obviously there are three concepts related to the post diameter. So it's proportionist, preservationist, and conservationist, right? So post width should not be greater than 1/3 of the root width at its narrowest diameter. That was done or said by Stern and Hirschfeld in 1973. And the preservationist concept said that post should have at least 1 mm sound dentin around it, and conservationist said that minimal canal preparation done to conserve as much as RDT as possible. What is RDT? Remaining dentin thickness. Remaining dentin thickness is the concept that we should remember throughout any endodontic procedure. As I was talking earlier about this lower lateral incisors, which have thin roots, right? RDT is a contributory factor there. While preparing, you can go with your hand files 2% and then limit to 4%. If you are going towards 6% of rotary files, then you should be very careful, and keeping in mind that it's not as conservative as possible. So try to always question yourself uh, about how best you can treat this case. And obviously, once you're loaded with information, concepts, related recent research, you can be making a better decision for your patient, right? So all of these factors have to be kept in mind, right? So as the diameter increases, the stress on the root increases. So obviously, fracture might happen. So to not do more diameter or more extensive preparation. That is what is recommended, right? Keep it as small as possible, and rigidity of the pore should not be compromised. At the same time, root dentin should be conserved. Both of these factors you need to do. As I was saying, you need to be balancing uh, the whole treatment plan. That is the best way. And the ferrule height, remaining vertical tooth structure, 2 mm is the absolute minimum. 3 mm gives you a good fracture resistance. So the greater the height of the remaining tooth structure of the crown, or the remaining, tooth structure coronally, more better is our fracture resistance and more better is the prognosis of the tooth, right? So that image shows you how that coronal tooth structure or coronal tooth is there, and try to maintain that thickness as much as possible. In cases where there is not much of tooth structure, we can't, obviously. But in cases where we can, you should be mindful that you don't unintentionally damage also, right? So it's best to have an all-round tooth structure for the encirclement of the cap on the tooth, right? To get better retention and better aesthetics as well. So case evaluation again is very much important. We should not be practicing hero dontics, right? So you need to know what you can treat, you need to know what you cannot treat, right? And you need to know what are the principles behind everything so that you can make an informed decision for your patient. So again, the worst case would be that at least the palatal tooth structure is there, and still we could try, you can inform the patient there is a prognosis is going to be really poor, shear stresses are going to be in play, right? So it might not last for a long time. But at the same time, the photo below, where there's no structure at all, and if we feel that let's do crown lengthening and then place a post, then place a crown, then obviously, even though you have done that amount of hard work, it's not going to resist that shear forces. So you need to know where you can do it, where you cannot, so that you can make a informed decision there. That's a pictographic representation where there's a complete ferrule, that is tooth structure all around 1 mm tooth structure, vertical height of 1 to 2 mm, and over that we give that prosthetic crown. Then the longevity of the tooth will last good for a good amount of time. And in cases where unfortunately we have a partial loss of tooth structure, and fortunately we have one side good thick tooth structure which is there, 1.5 mm of coronal tooth structure is available to us, then we can still be courageous enough to go ahead with this partial ferrule, right? And if there is no ferrule, then obviously it's a guarded prognosis, and we need to be clear about that fact. So 5 requirements which we need to keep in mind: minimum 2 mm dentin axial wall height, parallel axial walls, crown must be totally encircling the tooth structure, margins of the crowns must be on the sound tooth structure, your periodontal evaluation should be proper. Always do your periodontic work, respect your gums as well, because they are going to be synergistically helping us preserve our tooth, right? So you need to evaluate that earlier, and margins should not invade the attachment apparatus, right? So you cannot drill subgingivally extensively thinking that I will create a nice ferrule. So there are going to be repercussions to that as well. So you need to remember that. This again shows a wonderful image where you can see that the crown is going to sit on sound tooth structure, right? It has good amount of axial or vertical height, right? Even though the post has been placed 1 to 2 mm, and good thickness as well. So the stress distribution in such cases will be evened out, and thereby increasing the longevity of the tooth. So such cases is what we should aim for, right? Preserving your aesthetics, taking care of your gums, as well as making sure you achieve this good postodontic restoration, considering all the principles and the factors which we had discussed today, right? So this is how it should be. It should be on the finish line, the ferrule effect. The finish line is where your crown will sit. The finish line is where your ferrule effect should be there, and not on the contrabable over the core preparation. There's a slight difference here that needs to be remembered, so that our prognosis is well, right? And surgically crown lengthening cases, right? So where we were talking about the partial bevel, or I'm sorry, the partial ferrule placement or loss of tooth structure, you can make a attempt to crown lengthen the tooth, but not a lot, not a lot. Crown and root ratio should be always 2:1, preferably more than that is good, but 2:1. And if that is not the case, then again the shear forces are in play, and this could lead to a fracture. So what are the errors? Again, post is too wide, too short, ill-fitting post, lack of ferrule, or improper selection of the post or core design, right? So the retention factors here would be the post length, the post configuration cement which you're using, and the luting, how it is done, isolation, how is achieved properly. And the resistance triad here would be the vertical remaining tooth structure, the bevel, and the anti-rotation march, right? So Practical aspects, I will not be discussing much today, but as we all know how the post preparation has been done, the X-ray image earlier, as I had shown, you can use various instruments, including GG and piezo reamers, instruments where you can provide that post-paste preparation, right? Norman in 2005 had classified this post-endodontic restoration based on number of walls available, coronal walls, right? The axis preparation with all four axial walls was class 1. If one was lost, class 2. And subsequently, if both mesial and distal, walls were lost, then 3. And if only one wall was remaining, usually that is buccal or lingual, significant structure loss, then class 4. If there is no walls at all, uh, it's completely decoronated tooth, that's class 5. That is one of the classifications given by Norman in 2005. We need to be just keeping in mind. So, as we were discussing, uh, where to do what, right? So let's say the incisors and the premolars. I had just discussed the classification, class 4 cavity and bigger loss of substance. What is class 4? Only one remaining axial wall, usually buccal or lingual, significant structure loss. So if that is the case, then you need to know what type of post you can place, right? And what type of crown you can give. You can give a composite core buildup followed by your crown if at least one wall which is more than 2 mm is there, right? And you can use the core materials which are advanced core materials which are there, paracore, lexacore, which can be used as the core material instead of those metal post or fiber post, and achieve your target, right? So this is how you need to decide for restoring an endodontically treated tooth, right? And there are newer methods for post-endodontic restoration, obviously, which involve the fascies, the fiber reinforced composites, CAD/CAM technology, which is being used to get your custom crowns, inlays, onlays, right? If there is a sufficient amount of tooth structure coronally, then we need not take support of the root dentin, right? Where you're going to give your post, where you're going to give your just core buildups, and where you can directly give your endo crown, right? Where you can give a direct crown. This is where you need to keep in mind, and all of it depends on what? Depends on the amount of tooth structure which is present, right? Behind story is that you need to be taking care of all the principles which we have discussed to achieve that target, where we can confidently tell our prosthodontist to continue and give the crown, whichever type it might be. It could be veneers, it could be the partial crowns or the full crowns. It could be metal ceramic, it could be zirconia, it could be emax, whichever is the kind of prosthetic uh, material you want to your prosthodontist use, or you want to use at a later stage. But it all depends on the amount of tooth structure which is dependent, right? So if the coronal tooth structure is good, more than 2 mm, more than 3 walls, then you can attempt to give a core buildup, right? If a good core followed by your crown, right? If there is no wall, no ferrule, partial ferrule only, then maybe it is better to do a post, take help from your radicular space, take retention factor from there, and then continue with your core buildup as well as crown. So that is the decision which you need to make, and always keep that in mind, right? So as I was saying earlier, Ribbon is one of the advanced technologies which we use continuously for various applications. But here, since we are talking about post-endodontic restorations, Ribbon is one of the good ways where you can take care of the problem. The other image on the right shows you how a CAD CAM technology will help you build customized cast post. And that customized cast post will follow all the rules which we had discussed earlier in terms of the post length, diameter, right? And it will obviously give you the best possible customized version of your post. Again, the endocrowns also are one of the more advantageous places where there's not much of coronal tooth structure, but you have a good thickness, right? So therein you can use these endocrowns. And the disadvantage though here is that it is not meant for all teeth. uh, you need to know that where you can use that. And since they are more cement retained and less of you know uh, retained to a lock and key or retained to the structural composition of a crown, it might not stay for long. So you need to be uh, evaluating your case before you give an endo crown, right? Um, that's all about for today. Thank you all for your time. Uh, I hope I could make it informative for all of you.